Hello and welcome to the Health Policy Grand Rounds for today, our month of October. We are very happy to have Luke Hagenars here. He is a Harkness Fellow visiting UCSF for the year. So if you want to meet him, you can in person for I think the full academic year, correct? Yeah. Yes, indeed. So Luke has a doctorate and he is one of our Dutch Harkness Fellows in healthcare policy and practice. He specializes in the analysis of health policy processes through combined systems thinking and applied theory. His primary area of interest is complex public health problems, including the obesity pandemic. And I could go on in more detail about his background, but I think it'll be fun for him to just tell us about his research. For those of you who are at the UCSF campus today at Mission Bay, but are not in our room here at Mission Hall right now, we encourage you to come. We have a box of awesome cookies from Neighbor Bakehouse over in that corner for people to grab for snacks. So that might lure some people here, and the room is filling up as we go along. We're going to do question and answer with a handheld microphone today to make sure that people who are on Zoom are able to hear all the questions clearly. So when we get to Q&A, we'll be doing a bunch of microphone running around. So I will hand it off to you, Luke.
Thanks for that introduction, and thanks for having me do this grand rounds. I feel honored. I understand there's a lot of people at home watching and a lot of smart people in this room as well. So just to get started, I guess it makes sense for me to explain why the heck there's an elephant on the screen. And I guess it's a metaphor that's been used quite a lot to explain why we need system thinking. And the main message of the metaphor is that often researchers, policymakers, society at large tends to look at the elements of a system separately instead of envisioning the system as it functions as a whole. So in the picture, you can see, in this case, researchers who investigate the elephant's tusks as being spears, the elephant's ears as being fans, the elephant's tail as being rope, whereas, of course, the whole is more than the sum of its parts in this specific case, being an elephant. So I will talk at length in more detail about what this actually means for us as health policy researchers. But before I do that, I'll just guide you through this setup of my presentation today. So first, I'll tell a bit about why I actually sort of started to think in systems and to apply system thinking in my research by telling you a bit of my life story. And also, be more specific, the Dutch health system, because there's some interesting experiences I've had with it as a policymaker that sort of set me on this path towards thinking in systems. Then I will explain better what actually systems thinking is before I delve into the methodological details on how to do it. And finally, I will conclude this presentation with one slide on my ambitions during this year. So what brought me to IHPS? Laura Schmid, whom I'm working with throughout this year, in one of our first meetings, she called me a true policy wonk. And I guess she was very accurate about that. I didn't know that term. It's probably just my non-native speaking English skills that doesn't make me get such terms, but it's really true. I am a health policy wonk. And I guess that sort of started because of the fact that I was born and raised in this town in the Netherlands in between Rotterdam and Antwerp that is like in the very close vicinity of a very large Philip Morris factory. And that's the factory that you can see on the picture. And what is actually quite interesting about it is obviously it employs a lot of people in the town that I grew up in. So if you're talking health policy in the town where I was born, people will not always be extremely supportive of tobacco policies because it may, in their minds, like affect their livelihoods, right? So that's one of these systems elements that plays along there. It has obviously very strong ties to the municipality. And obviously in that town, there's very high smoking rates because the company would like give their employees presents with like big boxes of cigarettes at Christmas, you know? So, and perhaps also interesting to notice, you can see it's like directly positioned near a very large highway and especially like a very big corner of the highway. And that highway is on the route to France. So all Dutch people who go on vacation to France, which basically everyone does, they always like pass Philip Morris, and then they always know of Berg op Zoom, where I was born and raised, of being that town which has the massive Philip Morris factory. I also have another element of my weird background is that I was a former semi-professional road cyclist, which obviously is a lot about having a healthy lifestyle, but professional sportsmen, I noticed, also have a very individualist perspective on how their lifestyle is actually shaped just by their own behavior. That's sort of their paradigm. And I'll come back to that later, why I think it's not entirely true. Obviously, then I started studying health sciences, global health as a master's, then got enrolled at the Ministry of Health in the Netherlands for 7 years, where I worked my way up a bit. I spent a couple of months also at the OECD in Paris. During that period, or at least the last couple of years of it, I also did a PhD in health policy analysis, the cover of which is on the bottom right of my slides. It was basically about reducing paper and sugar for fiscally sustainable healthcare systems. So how can we improve the fiscal sustainability of healthcare by better prevention and reducing administrative costs in healthcare, which I think are perhaps the two most important, but also the two most neglected strategies for fiscal sustainable healthcare. I'll tell a bit about why I left the ministry. That has to do with a bit of frustration and working in policy, but also on a position that was created in Amsterdam to basically combine complexity science methods with health political science theories in the field of obesity, which was just right up my alley. I started there last year, and during that year, I also applied for the Harkness Fellowship, which is funded by the Commonwealth Fund, which I'm guessing most of you will know. And for some weird reason, they selected me. As I mentioned, I got in touch with Laura Schmidt. Well, we had a good click, so we decided I would be positioned here to do research here with a systems lens on obesity policy processes in the US. And when I get back home after this academic year, I'm supposed to share what I've learned in, for instance, like a blog in a leading medical journal and presentations in my network in the Netherlands. So I guess the Dutch health system, I'm not sure which one of you will like know it a lot, but probably none of you will know it like in detail. I kind of do, and it's quite an interesting microcosmos because there's actually quite some similarities between the Netherlands health system and the American health system. There's also big differences, of course, but some things are actually quite similar. So important to notice is I've noticed now that I've been living in the US for a couple of months that Americans sometimes tend to idealize European welfare systems. And I'd like to nuance that a little bit. Obviously, the Dutch welfare system is better than yours, but it's not perfect in the least. And one indicator of that is that we basically have quite poor health equity. So the Netherlands is the orange bar over here. And you need to consider that we're quite a wealthy country. The Netherlands is wealthy. But people that are on low incomes, that are lowly educated, they basically have quite poor health outcomes and also poorer than in other comparable countries. And that basically has to do with smoking, obesity, social determinants of health. There's a lot to be said about that. Do contact me if you're interested. But the Dutch government has been kind of neglective when it comes to protecting health, to protecting people from the harms of smoking. And just to allude to the marijuana symbol, the Netherlands has been very liberal, historically speaking, which also means that the government has been quite reluctant to do anything about behavioral health problems. And now you can see that also in obesity. Obesity is not such a big problem as it is here, mostly because of, for instance, our cycling infrastructure, but it's been kicking up since 1990, uninterrupted, basically. So it doesn't go well in that respect. But at the same time, our healthcare system actually compensates a lot for these social commercial determinants of health problems, because the system is consists of mixed financing. So we basically have a managed care system, and actually some architects of the ACA, apparently back in the zeros, they also visited the Netherlands quite often to sort of learn how we did that. So there is managed competition for medical care, there's a single pay system for long-term care, and tax-based provision of social care public health by the 350 municipalities that we have. The access is actually quite good. You can see that in many indicators. So out-of-pockets are quite low, only for secondary, tertiary care. The system is very much GP based, and basically everyone is also enrolled with a GP that they kind of know well. And obviously it's a small but very densely populated country, so care is always right around the corner, basically. Quality metrics are not that bad, like readmissions, amenable mortality rates. They're good if you compare it to other countries. And at the same time, we do not spend a lot of money on medical care. So the Netherlands is sort of renowned to be expensive, and that's been actually sort of a statistical artifact of OECD data, which made us second behind the US for many years. But that was because other countries didn't report their long-term care spending good enough. But if you look at the medical care spending of the Netherlands, is actually like even below OECD average. But our total spending is like comparable to France, Germany, Belgium, whatever. And that's just because we spend a lot of money on long-term care. And that is a bit of a problem because our country is not that aged yet as France and Germany, for instance. So despite sort of these kind of good healthcare performance metrics, I think the system is very unsustainable. This is probably a bullet that many of you will shock, but I think it's actually true for the Netherlands. So our volumes in medical care are very low. There's not many hospital beds. There's quite limited use of MRI and CT scanners and those kind of things. And that, for instance, caused big problems with the COVID pandemic because there simply wasn't a lot of surge capacity. And now also like GP limitations are really straining the system to its maximum. The fact that we have mixed financing, but also basically all private, not-for-profit provision makes the system very fragmented. And because there's also a culture to be very strict in privacy regulations, it's a very difficult system to do data governance, which causes the system to have high administrative costs. I guess not as high as over here, but still like quite considerable. The system is also not very ill-suited for frail elderly. So in many countries, life expectancy has been declining or stabilizing. In the Netherlands, that holds through like before the pandemic also, especially because of rises of mortality rates among the 80+ population. And that's been linked to like this financing system. And the fact that we have freedom of insurance choice also sort of causes some solidarity problems. Not as big as around here. But for instance, if you'd be a student, you'd get a healthcare allowance to pay a premium, and that allowance could be higher than the premium you would pay. And you're talking about like the more well-off, knowledgeable, healthy folks that basically don't pay that much. And probably the most important one, I just mentioned that long-term care spending is pretty high, even though our population is not as gray yet. But still, the perception in the population is that we have very low quality of elderly care. There's not a lot of proof of that, but it's sort of a political image that's been quite strong. And for the health workforce folks amongst you, this is a visualization of what that actually means in terms of health workforce eating up the other parts of the workforce in the Netherlands. And it basically forecasts that I think 1 in 3 of all workers would work in healthcare in 2060. And obviously that's totally unsustainable. And there's quite a lack of political willingness to basically deal with this properly. Perhaps I didn't mention enough already, but like the medical care system is quite efficient, but still there's a very strong assumptive world. And I'll explain what I mean by assumptive world. A strongly held set of assumptions about the world and the self, which is confidently maintained and used as a means of recognizing, planning, and acting among policymakers, planners, finances, that the system is inefficient because there is low value care, because there are like unnecessary hospital readmissions, because there is sometimes a lack of communication between different brackets of care. And obviously this all holds true, but if you look at the macro numbers, the problems really aren't there in the Netherlands. They really are in social commercial determinants, long-term care, and administrative costs. So not necessarily the primary process of medical care delivery, but more like the system around it. And it's been a very difficult thing for people to realize, and I sort of got a bit frustrated with that. So the idea of trying to investigate these things from a systems lens really appealed to me. And I'm not just making this up, because this is a draft of a paper that we submitted this week, actually, which shows that there is basically very minimal political attention for lifestyle and social determinants of health in the Dutch parliament. So the like 0 to 10-ish% of their parliamentary contributions is spent on social commercial determinants. And basically all the rest is about healthcare, like basic benefits, the deductible, low value care, competition, healthcare workforce stuff. And obviously that's not unimportant, but the balance is just, it's just not there if you look at it from a more factual point of view. So I hope I've sort of guided you through my process of why I started to think in systems, but now I'll tell you a bit what that actually means. And if you're really interested after this talk, buy this book and read it. It's not that big. It's written by Donella Meadows, who was like an author of the Limits to Growth report back in the 70s. And it's awesome. It really makes you rock your world. And it's just awesome. And basically what system thinking encompasses is, first of all, this notion of emergence. So the whole is more than the sum of its part, the elephant basically, but also that systems therefore have system behavior that is very different than what you'd expect if you count up what the elements of the system would think are doing in themselves. And these systems can also be very path dependent. So there's a lot of like system archetypes out there: drifting goals, escalation, tragedy of the commons, success to the successful, those type of things. And it has such a purpose because systems tend to be called complex adaptive systems, by which is meant that they are dynamic. So meaning that system parts and their connections produce their own nonlinear and uncertain feedback patterns. And then they're also adaptive, by which means that things that come from the outside of the system, they will make the system adapt itself to it. And I'll just use one metaphor that's used quite often: the swarm of birds. So obviously the behavior of that swarm is very different than the behavior of all these individual birds added up. The swarm has sort of a purpose that is like ingrained in the intuition of these birds. So they want to migrate to some place and they will just go there regardless of what happens. And that last point, regardless of what happens, basically falls back to the fact that their system is very dynamic. So there's a lot of feedback loops in that swarm that will make the swarm behave as it does. And also if there would be like, I don't know, a predatory bird flying into the swarm, they will just circle around it and continue on their path towards wherever they're going. Often also mentioned in this literature, and perhaps some of these terms may sound a lot like jargon, and that's because they are. The whole literature around complexity is filled with jargon. It's sometimes very incomprehensible and inaccessible, perhaps also because it sort of originated from mathematics mostly. But quite an important one, I guess, is the notion that complicated systems is not the same as complex systems, is not the same as chaotic systems. And there's a lot to be said about that, but I found this really good example in a primary care journal, where they basically mentioned that medical specialty care is more like a complicated system. GP care is more like a complex system, whereas a traffic collision with many victims is more like a chaotic system. Meaning that GP care is very unpredictable, but there's still some logic to it. Whereas in the traffic collision, there's often not that much logic to it anymore. People just need to act. Whereas in medical specialty care, it can be a very long and lengthy system, but it's highly standardized. So that's not so much the case as in GP care, for instance. So how to do this? I guess sort of the philosophy of system thinking is very much opposed to the philosophy of reductionist thinking, because it really urges one to look at the interconnectedness between system elements instead of looking at these elements in themselves. That also means that you'll be looking at not A to B, but A to B to B to C to C to D to D to A. If you're still following, so you really need to think in circles. It's really about understanding not just parts of the puzzle, but the puzzle in itself. And these other metaphors that are on these slides that I think is quite useful to understand the difference between system thinking and reductionist thinking. What I will be talking mostly about the rest of this presentation by mentioning my own research is that system thinking involves in thinking in these feedback loops. And feedback loops create vicious or virtuous cycles, or sometimes also balancing feedback loops, meaning that the system is very much resistant towards any change. I'll come back to that later with good examples, at least I hope. So this is sort of a rapid description of what thinking in systems is. I think we need to do it, first of all, because we already do think in systems, but we do not do that as explicitly as perhaps we as researchers especially want to do that or should be doing that. It's also really about trying to understand the system behavior instead of mitigating the events that the system keeps producing. And there's a lot of theoretical frameworks around doing that. And mostly they revolve around the fact that, for instance, obesity, if you look at obesity just by its event, it's the behavior. But the structure is the obesogenic environment. The goal behind the obesogenic environment is, for instance, profit maximization by the food industry. But the paradigm that lies beneath that also is the notion that people tend to perceive obesity as an individual problem. Quite important also, and sometimes quite fun, is that it allows one to better understand or predict potential unintended consequences. Just a couple of examples: tobacco taxes do increase cross-border shopping. For instance, in the Netherlands, a small country where tobacco is quite cheap in Germany. That's the simple one, but for instance, road traffic jams are often thought of that you can just solve them by widening roads. But what that does is basically get more cars on the road. So in the end, there's more cars in the same amount of traffic jams. But perhaps more important is that these unintended consequences can often take a very long time. So for instance, if you want to increase green spaces for physical activity, that's obviously a good idea, but what that does also is increase the popularity of a neighborhood, which then leads to real estate prices to increase in that neighborhood, to over time increase the pressure to develop in that neighborhood. And where are they going to develop? Of course, green spaces. And that's obviously a multi-decade sort of balancing feedback loop that then eventually leads to less green spaces, even though the policy goal was to get more. And perhaps more of a reality check, in many public health problems, we're not like progressing as much. So we just need fresh thinking. And this Lancet paper by Harry Rudder and colleagues really just made a plea for that just because of that. So I hope that I've convinced some people that this is useful, but probably I've also confused a lot of people because, well, if everything's connected, how the heck are you going to do systematic research on that? So now I'm going to talk about my own experiences in doing that. And I guess I'll just have you read this quote by Donella Meadows shortly. So I'll shut up. So yeah, I guess the point is clear, right? She basically says that you cannot describe a system because words and sentences come only one at a time, whereas a system happens all at once. So you need to visualize it. I think it's quite an important quote, this one, because especially like in the social sciences, sociology, political sciences, there's a lot of theories that are very systemsy. They use a lot of words and language that like was also used by these mathematicians who did the system modeling, but they never visualize their theory. They just describe it, which makes them quite difficult to understand for people who want to actually apply them. So this book by Barbara Johnson and Penn, I think fills up a very important void to actually explain better how to do this, because there's not a lot of methodological standardization out there. And they basically point out there's different types of system maps that you can opt for. And they can be either very qualitative in terms of what the data is, or very quantitative. They can very much focus on trying to understand, the causes of obesity, but also how to intervene in the obesogenic system. Just to give you one example from a colleague of mine, Alexia Sawyer, she basically made a system map to understand why food systems become food deserts. And there's this vicious circle involved where decreasing household budgets lead to less healthy food consumption, purchasing, which leads obviously to these stores not stocking healthy foods, which then also increases transaction costs for people who live in the neighborhood to eat healthy food because they have to go to other stores. So that's a clear vicious cycle. Sort of my position in this field is I'm more of a qualitative researcher, but I also really like the system dynamics idea of trying to forecast how to change the system. And obviously forecasting is very difficult, but I think it's relevant for policymakers because policymakers tend to live in the future rather than the past. And I both look at systems because now I've also turned into a systems nerd, but I'm still also a policy wonk. So interventions I need to better understand also. In terms of types of data, there's quite a lot of emphasis in the literature to build these system maps in a participatory approach. So for instance, with researchers, policymakers, community members, whatever, professional groups. And there's also a lot of approaches that are a bit more difficult to understand. For instance, rich pictures, just having people literally sketch the system that they're engaging with. It's quite easy to understand how to do that, but to build a system dynamics model to sort of try and predict system behavior, obviously it's very hard, which also makes them very much closed for like lay people, but still important because we also need a sophisticated understanding of things. One example of system dynamics modeling in obesity of a colleague of mine, Luis Krielaert, a brilliant PhD student, who did a system dynamics model on the influence of social norms on obesity. And they've sort of built a model on the basis of a cohort study where they asked people to report which physiques they think are most attractive, which they want to look like, which their group which they think their group wants to look like, those kind of questions. And her model actually came out to find that social norms account for like around 3 BMI points. So quite a powerful statement that I think, but still based on thorough analysis. And my position here is definitely a bit more on the formal, more harder to understand system mapping methods. Laura will be able to testify. But also really, I'm not like against participatory approaches. I like chaired a session with researchers to understand why obesity has been increasing in the Netherlands in poorer neighborhoods for 30 years already. And that was very participatory, and I also like doing that. So these are different types of system mapping methods, and that's fun. But like very often I hear people say, well, if everything is connected, and people will obviously acknowledge that everything is connected, how are you going to establish system borders to be able to at least understand part of the system that perhaps makes us understand the world a bit better? Or how does one avoid developing system maps such as this one that really don't add much value but by just pointing out that stuff is complex? And that's a good question. That's a really good question. I guess my experience in doing this over the last year has been mostly about not trying to understand an entire system, but to understand the system's core components and the dynamics that they portray. And to give you one example, actually from my policy background. So this is a stock and flow diagram of the administrative burden in healthcare. And stock and flows are a system dynamics model basically, and I like them because they really force one to explicate the system elements that are more foundational and the system elements that are less foundational. And stocks then are like defined as foundational elements of the system that are not volatile and also theoretically quantifiable. So administrative burden is difficult to measure, but it won't disappear overnight, whatever policy will introduce. And obviously, if you're interested in reducing that, it's the foundational element of the system. So the Dutch government approach is basically to negotiate with stakeholders in true neo-corporatist fashion, which procedures to eradicate. So they very much focus on increasing the outflow of the stock of administrative burden by schrapsessies, a very nice word to pronounce in English. But it's basically around stakeholders discussing which administrative procedures they find obsolete. And of course, that's not bad, but like there's a whole system behind administrative costs that actually increases the inflow of them, that like are their root causes. And the government really sort of neglects that by just focusing on trying to reduce the current burden. Um, so I guess that is really a fix that fails because if there is still a lot of data requests by stewards, finances, patient organizations, professional groups for all kinds of data, and you get people to agree on removing certain data further down the line, the data request still remains, right? And just to give you one example, there was this thing around chronically ill patient who would have to report that they're chronically ill every single year for their insurer to like be able to compensate certain procedures. So the insurance company could be able to say, well, okay, we're gonna not have you do that because you're chronically ill, so you'll stay chronically ill. But if the steward still like has the necessity of getting the data of the amount of chronically ill patients who need certain procedures, then the data request will still remain in there. So that's the B1 in this Silk and Flow diagram, where like getting certain administrative procedures out of the system will basically flow back into increased demand at the beginning of the system. So in the end, like a similar administrative burden to the system. And at the same time, I mentioned that there is quite a strong like focus in the Netherlands on like squeezing out every single piece of efficiency in the medical care system, which is not bad, obviously, but at the same time, the policymakers, in my experience at least, they have very little knowledge of healthcare delivery itself because they're not healthcare professionals, they're civil servants, basically. So the fact that there is a lot of administrative burden makes the system at large not as efficient as you'd want it to be, not the primary process of healthcare delivery, but the system of healthcare delivery, which then leads to a big policy focus on efficiency of healthcare, for which obviously they over time need a lot of data to be able to follow that. So in the end, probably more administrative costs. So really a fix that fails. I'll now turn over to a study that I'm in the process of wrapping up, and it's been very much fun, but also very difficult, which is about the system of obesity policy stability and change. And when you're talking about obesity and systems, it's sort of obligatory to show this figure by the UK government that basically shows the obesogenic environment or the obesogenic system. And obviously, it's awesome to be able to show people, well, you know, it's more complex than calories in minus calories out. But at the same time, showing that stuff is complex does not necessarily lead us to a better understanding of that complexity. And it also stifles policymakers. They would just be like, well, if it's so complex, then I'll just like do other stuff with my scarce time. So knowing that, and also knowing that we tend to not really help policymakers with the political process of getting the policies adopted that we think are worthwhile to reduce the harms of the obesogenic environment. And the fact that I already did such kind of study. So I studied, for instance, the soda tax in Berkeley, Cook County, in Philadelphia, not whether it works or not, but how people manage to get the tax adopted with like political science theory. We decided to not map the system of the obesogenic system, but the system that can actually change the obesogenic system. So I did a literature review. I used Vensim software to be able to do that. And that ended up like this, another Harendogram. Yeah, so we sat together and we were like, well, no one understands it. And actually in the beginning, when I sort of finished this, I was a bit like surprised that people didn't get it, because I got it because I was like spending so much time working on the thing. Yeah, for sure. Well, not enough, I'd say. Like just one example, there's like the Vensim software lets you like do a feedback loop function. And it came up with like more than 10,000 feedback loops. So it made no sense. So we decided to more strictly use theory to structure and basically weed out the map. And also use stocks and flows to really force ourselves to like get rid of the stuff that's not so important and to keep in what's really foundational. And we used punctuated equilibrium theory. The political science theorists amongst you will know this one, but it basically posits that policy changes a lot and that there is a huge amount of small policies and small amounts of huge policies. meaning that there's often very long periods where sort of nothing happens, or incrementally an issue is like handled in the political arena by some like minor subsystem. And then there's like a focusing event, boom, there's a big change of the game. And that change of the game can actually be institutionalized in a different type of policy. And our theory here was that currently we are in a situation where obesity policies tend to focus on the individual. We need to move onwards to the obesogenic environments in order to really tackle the epidemic. And if we do that, we need to be able to sustain that. Otherwise, it's just a one-off policy that's not followed up properly. So this is a bit more comprehensible, this system map of why today's obesity policy is basically inert. And I'll guide you through it. So above here, we have the stock that people tend to see obesity as an individual problem. Literature is quite clear about that. That increases a lot of resistance amongst politicians and policymaking institutions towards tackling the obesogenic environment, in the technical term, upstream obesity policy punctuations. But it does like lead them to implement all kinds of smaller policies that target the individual. I guess this already is something we know, and also that it's not just something that came out of the air, but it's like commercial interest in the biomedical sector that fuel that individual narrative. But by connecting all these dots, and that's actually this arrow and this arrow, we found that the system is actually not inert. It's actually worsening, because individual-oriented policies, they increase the focus on the individual in public framing of obesity, as well as increase the hold of the commercial industry and the biomedical sector on the topic. So their problem ownership increases or strengthens. So if I try and translate that in more practical terms, it might very well be true that improving clinical practice for some may frustrate progress for many through tackling the obesogenic environment. So I'm very pessimistic, but now I'll turn into a more optimistic notice to at least try and understand how we can get rid of this vicious cycle, how we can break it. And I think these factors are a bit difficult to see for the audience, but basically what you need is a focusing event. But a focusing event in itself is not enough. And for instance, COVID obviously drew a lot of attention also to obesity, because there were a lot of people with obesity that ended up in hospital. But because it was not encompassed by dominant framing of obesity as a societal problem, it actually increased stigma. So there's been some studies in the UK, in the US, and Canada that have shown this, that like the way the pandemic focused a lot of attention also on obesity just increased the stigma. So that's not good. So, but we confirm basically that this is what you need to do to be able to change policy, have a focusing event, change the discourse around it, to be able to get a lot of political momentum to in the end change policy big time. And basically what the literature finds is that we should reframe obesity from a health issue to a societal issue. So that may mean that we need to focus more on the societal consequences of obesity, such as stigma, but also losses of productivity, those kind of things, instead of like all these different diseases that obesity causes. So sort of translated again, that also means for advocacy to perhaps focus less on obesity as a problem itself, but to focus more on the way in which society problematizes obesity, to be able to decrease the resistance amongst policymakers to tackle the obesogenic environment. This is perhaps a bit counterintuitively, but well, at least it is what the model sort of pointed towards based on the literature that we included. And actually, like weight stigma groups, that's like the left and bottom part of it, because like this part is more about the interaction between framing, focusing events, and breaking through political resistance. But obviously, framing doesn't change in itself. It needs advocacy, and that's what's in the bottom and the left of the model. Weight stigma groups really do focus on the societal consequences of obesity, while at the same time often also being in favor of policies that tackle the obesogenic environment. So I find them very interesting in how they perceive this issue. Yeah. So this one is the last one, and then probably people's heads will be sort of need some ventilation. But the idea behind this one is that you can have, in the end, a change towards policies that really tackle the obesogenic environment, and instead of like saying to individuals that they need to live more healthy, that is necessary to be able to move towards obesity policy integration. I noticed that like these terms, intersectoral collaboration, obesity policy integration, they're less common around here in the US. It's more of a Euro thing that people are talking about that. But basically what this figure, first of all, that we had it shows is that obviously that means you need to have like sustained community engagement and sustained engagement of non-health silos like finance, trade, spatial planning, agriculture, education. But like attempting to do that when the individual framing is still dominant is basically a waste of your time, because they're not going to do it if they don't perceive it to be their problem, or it to be a collective problem in the first place. But if you do have such a like focusing event that like changed policy for the like good, you need to be able to sustain that, and we need to be aware of the fact that this basically costs a lot of time, because reaching out to communities, having meaningful engagement with them to be able to have sustained interaction with formal policymaking institutions just takes a lot of time. The same goes for reaching reciprocity between health and non-health silos, because I mean, if you're a policymaker working on climate, your first thought will not necessarily always be to also do stuff related to obesity, even though these fields can really cooperate well. That just takes a lot of time. And finally, on the left of this figure of the stock and flow, again, the importance of information that perhaps is less related to health as a cause of health as a consequence of obesity and behavior as a cause of obesity, and more related to what actually drives behavior, but also what is the societal consequences of obesity, because those are the things that like finance people will care about, that stigma activists will care about. They won't care about like obesity prevalence, but stigma reduction. So if those types of things are fueling the obesity policymaking processes more, the literature suggests that it helps create obesity policy integration. So if I wrap this up, we're still struggling a bit with like the core message. Like stigma is, we were thinking of like losing stigma instead of weight, but stigma is like an example that doesn't show up as strongly in the literature that we looked into, but de-individualizing does. It's a broader moniker, but that basically is what you can think of is the core message of this whole study. For healthcare professionals, they may mean that it's quite difficult for healthcare professionals to not to do this, because well, you work with individuals, right? But if you would talk about obesity in like media policy, it's really important to not like focus on the individual cases, because people already have this notion that it's an individual's fault, right? So policymakers, the message to them is, I was a policy wonk, so I was happy with incremental progress. I did a lot of stuff related to like getting the combined lifestyle intervention in basic benefits in the Netherlands, and now I kind of regret that, because I should have used that time to convince more folks that it's not an individual's fault. That probably is more effective over the long run. Advocates, like I mentioned, reframe by alluding to societal consequences instead of all these diseases that you get. And the research is also like to have them fuel that process. I mean, there's so much research already on behavioral causes and disease effects of obesity. We really need to dig a bit deeper, I think. So I think I'm doing well in terms of time, but I still have, I think, 2 slides left. These are sort of my methodological lessons of trying to rework a horrendogram to something that's actually useful. And actually, I need to thank, I mean, the process of translating the horrendogram to 3 systems maps that actually mean something, that was something we did back in Amsterdam before I started this position. But to then translate the manuscript from very jargon-filled political science meets systems meets public health thing that was just unreadable, I need to thank Laura a lot, because she really helped us out a lot in improving the language to actually people understand what we found. But I guess a main lesson that I drew is to really aim for feedback loops rather than just to show that stuff is complex. And that's not easy. That's not easy, but I was lucky enough to have a theory that could really guide us through this. And this is probably not easy in public health because public health is so empiricist driven, right? And less theory driven. So reach out to the social scientists in ISPS because they may help structure the maps. And really, this is not a linear, straightforward process. So systems thinking emphasizes that stuff is not linear, but the method of doing that is not linear at all. It's really very much back and forth between trying to hypothesize a system, collecting data, and analyzing that data, and going back to theory, etc. Because it's just not as straightforward. And that will make your head explode. I've had many days when I was like spending a whole day working on that model, and just my head ached, so I had to get out for a run, a bike ride, because I had to. And I guess what I found quite fun in being in ISPS for a couple of weeks now is that I've met so many different disciplines: sociologists, nurse practitioners, anthropologists, economists, physicians, obviously, EPIs, economists, a lost political scientist here and there, and really use that to your advantage, because we had that sort of range also, and it's very valuable. It really is. This is my last slide, just to tell a bit about what I'm trying to do here. So the proposal that got me into the fellowship was to compare obesity policy networks in San Francisco to Amsterdam. And that's kind of what I'm going to do, but probably in a more purposefully sampled manner, by investigating advocacy related to pouring right contracts that people of the entire UC system are trying to tackle. But also, for instance, to draw a network map of big tobacco sold and big food, and a couple of other minor things. And obviously, my sort of niche is really combining systems thinking and applied health political science theory. And I'm just going to do that over here now with case studies and fun commentaries. And of course, meet as many people as possible. So if you're interested to know more, just give me a call or just drop me an email. So bedankt voor je aandacht. That means thanks for your attention. And yeah, think of the elephant, I would say. Any questions?
I have a question. I wonder if you would comment, Luc, on the time frame of change, meaning the time between something like a focusing event and a true reframing in government. And the reason I'm bringing that up is for two reasons. One is tobacco. In the US, we had a focusing event in 1964, which was Surgeon General's report. It took 50 years before there was a real reframing in terms of the FDA taking responsibility and making some policy changes. And now, today, not today, actually for decades, now we have what I would say might be focusing events on gun control in our country. And we still have, you know, a big part of the country saying it's an individual problem. Guns don't kill people, people kill people, it's mental health. Yeah. So we have that kind of focusing event. And I'm thinking, like, is it going to be 50 years now before we have, so my question is, what kind of time frame do you think of for this type of change to happen?
$1 million question, right? Let me get this slide up there. So punctuated equilibrium theory basically holds that there's a lot of small policies and small numbers of huge policies, which means that the histogram is very stochastic, it has a very, or leptokurtic, I must say. So it has a very long tail. And that dynamic apparently is much stronger over here in the US because your political system just produces so much institutional friction. So that's yeah, I cannot help that. What is, yeah, it is true. Like in the Netherlands, I guess it would be a bit more normally distributed. It would still be very leptokurtic because basically all policy systems are, but it's known from the literature that the US political system and actually authoritarian political systems, they much more have that dynamic with like very long periods of basically nothing happening or incremental progress or decline, and short periods with massive, but really massive changes. So yeah, I can't really help that. What I would want you to what I would want to talk about also is this study that actually people did of the energy transition in California, actually, where they actually modeled this specific thing, and also to try and predict how much time it will take for energy policy to switch from fossil fuel to renewable energy. And I think it like took decades also, and it also was very stochastic. So you'd have like a policy that would go for renewable, then a bit later it would go back to fossil, but like over the long run it would go to renewable. But their main finding, which I found quite important, was that as renewable in this case turned into like a bigger economic power, that process like rapidly accelerated. So yeah, there's no single answer to your question, but other than that, you need to consider the institutional context, as well as the fact that focusing events in themselves are probably necessary, but never sufficient. They need a good advocacy strategy. They need often long history. And in terms of like investigating this, the advocacy coalition framework, that's another very systemsy political science theory. They basically suggest you to look at things over a horizon of 10 years or more. So yeah, sorry for being pessimist, but yeah.
This is just for Zoom, right? That's why we're doing this. Yeah. Hi, Naomi Bardak. Great talk. So very interesting. And I learned a ton. I have two questions. One of which, can you talk a little bit more about in your analyses, is there math and equations? Like, do you do any of that, or is it all more on the qualitative? Like, how do you sort of do that?
Yeah, so I'm interested in the method and the way of thinking to be able to like force ourselves to be more systematic in trying to use qualitative system maps to hypothesize future scenarios. But I don't do like the quantitative models that I've shown you about the social norms. There's many people who do that. For instance, like also this renewable energy example that I was telling about, that is a quantified model of political change, which I find funny that they are able to like put it in numbers. But I don't do that myself. Yeah.
And then one other question just about climate change. So to me, the projects that you put up there, like climate change could also potentially be on there as a list of things, and it seems like so pressing.
Yeah.
And so have you thought about that? And I'm guessing there's lots of people thinking about how systems dynamics is related to climate change and how we might do that, but have you considered doing that?
Yeah, I guess like all these climate change models, they're always system dynamics models, and they have a very long history in doing the system dynamics modeling. And at the same time, I think there's also a more active community of political scientists using theories that use a lot of systems jargon to better understand how to do climate advocacy. And not too long ago, there was actually a review of like 70 applications of that advocacy coalition framework in climate. And what I found very interesting about it, and I'm also referring to it in the discussion of the obesity paper, is that they found that scientists were often policy brokers in climate because climate change information is so technical. And what that did also is politicize scientific information around climate change, strengthening both the pro-climate coalition's beliefs as well as the pro-fossil coalition beliefs. So I guess what I'm trying to say here is that these studies show very well that even the very technical information of climate is very political in its nature also, and not realizing that can have very unintended consequences, for instance, by just fueling like polarized debates around such topics that we should all probably think are important. Yeah, for sure. Yeah. Yeah. Yeah, fully agree.
A question from Zoom from Rob Lustig. By using UK foresight with non-overlapping circles, you can assume that all phenomena are primary. How do you determine what phenomena are upstream and which are downstream?
Yeah, I guess that's also the main criticism of the UK foresight map, right? So the criticism on that map is, first of all, that it just shows stuff as complex and stifling policymakers, but also that it still has the energy balance at its core, and also therefore leading to a system map that is very much focused on the individual as well as like what's around the individual, but then at the same time sort of fueling the narrative that it's an individual's complex problem. Yeah, like in terms of structuring a system, I think what is very important is to keep realizing that every single system is a system map, is a mental model. So it's not like the one truth that rules them all. It's the mental model of the person or the group that made the system map. And for instance, a system map study that we are currently hopefully wrapping up, the PhD student is taking a little time, which is about like why did obesity increase since 1990 uninterruptedly in poor neighborhoods in the Netherlands? We really wanted to focus on their environment, not the individuals living in these neighborhoods. So we decided to structure the system by focusing on the food environment, physical activity environment, the socioeconomic environment, and the sociocultural environment. And through that, framing really the system structure as we think is important to explain why it's been rising. So yeah, not an easy answer either, but I guess like just realizing constantly that you're dealing with a mental model instead of a very objective or one in a kind truth.
Luke, thanks. This is an interesting talk. I'm trying to like think about the systems mapping relative to other sort of causal frameworks I understand. And I think about causal diagrams that are used in epidemiology a lot. And there the focus is specifically on being acyclic. And so, and that's sort of like part of how you can sort of identify effects of one given intervention on your outcomes of interest. And so can you here within systems mapping use that as a framework for intervening to sort of highlight the feedback loops, and have people done that? Is that something you're thinking about trying to do?
Well, I guess like in most of these system mapping methodologies that I've shown you in these two slides, the focus is really on getting us to better understand feedback loops. But there is some nuance to it. For instance, Bayesian models, they also are in essence linear, in the sense that A leads to B, leads to C, leads to D, leads to E. But you can also apparently integrate in these models different time periods of one factor. So I'm not sure if that makes any sense, but then it would like create a model that has some feedback in it with a bit of a workaround. But like you're saying, like if you really have a very specific research question that is just about knowing what A leads to B, that obviously is important too, because I do need to mention, like in my models also, it's based on empirical evidence and some theory where there was really lacking. And the empirical evidence is mostly about reductionist questions that examined how A led to B. So we need that in order to also understand the system at large. So it's not like a normative, like being against or like favoring the one over the other. It's not nothing like that.
Another question from Zoom from Laura Schmidt. Fascinating talk. It seems to me that there's a good analogy from the tobacco experience. There was a paradigm shift when secondhand smoke became the focus of policymaking. This shift shifted the focus of the debate off the individual health harms and onto societal consequences.
Yeah.
Is there a secondhand smoke narrative lurking in the obesity debate?
It's an interesting question. I guess it also alludes to the fact that these shocks, the focusing events, often people use the example of like nuclear catastrophe or a major pandemic, but they can also be more minor. For instance, like the report of the Surgeon General or like lawsuits. For instance, in the Netherlands, in long-term care, the fact that why we give so much money, it was also like strengthened by a decision to give more money because there was like a scandal of the state secretary's father not receiving so good health long-term care. But that was like a personal NS1 experience that sort of triggered the debate again to strengthen what was already there. In obesity, I think, like the externalities Laura is basically referring to, I think there's many externalities in obesity, and I think I'm looking at the two economists in the room. It's just so expensive. The economy for like employers, for taxpayers, for premium payers. It's so expensive, especially in this country. And as a more direct example, this example I've shown you of the study where they've basically shown that social norms produce obesity. That's the same thing, right? So it's not like that you have smoke around you, but the fact that you're living with people that have obesity really increases your risk to get obese as well, because it's the norm. So it's more, I guess, more subtle, but still the same idea.
One more question. I think there's another room coming in here.
Okay.
So talk about one that's been waiting online.
Okay, so this is from Hillary Seligman. Thank you for the really fascinating talk, Luke. I'm hearing two key lessons. One, start talking about societal causes and impacts. And two, stop talking about the individual level of causes and impacts. For many reasons, the first seems much easier than the second, given how entrenched the latter is in both healthcare systems. Can you weigh in on the importance of both happening together, or the relative importance of the two strategies? That is, can we have success if we're doing one well with weaker effort towards two?
Yeah, I've been thinking about this a lot, because like the message that we need to sort of improve clinical care for people with obesity is quite harsh. What is perhaps impossible or not, I'm not sure, is to basically improve clinical practice for people with obesity without telling anyone about it. If that makes any sense. So people that do that, really awesome and fascinating and good. But if you're called by a journalist to talk about obesity, for them, just decline, just forward them to the food industry. That's in this case not a very good idea, but forward them to, I don't know, someone who works in debt relief, who then can explain how debt can actually get people to become obese because of not being able to afford healthy food. So I guess it's really a matter of making the medical field also realize that, which is not easy, but yeah. Yeah, that's so important. So in education to also include that and those things, but so do improve clinical practice, but stop bragging about it. It's sort of my way forward.